We'll be going over the cardiovascular system of the heart. As you know, there are three components of the cardiovascular system. One was the blood that we talked about earlier, red blood cells, white blood cells, platelets, hematocrit, how do we make the red blood cells? What are the different white blood cells? So one component was the blood. Second component is the heart. As you know, we're going to be spending time. What is the high heart rate, low heart rate? What is the effect of heart in certain conditions? We will discuss awful lot of heart related topic today. And the last component happened to be the system of blood vessels. So this gives you an idea about the pathway of the blood through the heart and the lungs. All right, it's important to review your anatomy. These are all anatomy. You should know the pathway of the blood, but it really doesn't matter where we start off with. Say, for example, you start off from your right toe right here, you know, carbon dioxide is going to go to the blood. All right, so these are all veins or the capillaries first, actually, capillaries, and then it will merge into the venules and then merge into the major vein, which is vena cava. All right, and you have the superior vena cava and inferior vena cava. In this particular figure, they just showed you two from the similar branch, but it's not so. Anyways, you have the right side that happen to be right atrium and passing the AV valve. These are the AV valve. This is the right ventricle or the inferior chamber, atrium or the superior chamber. The valves in between them are called atrioventricular valve, AV valve. So the blood passes after the heart contracts into semilunar valve. Again, you could see two of the SL valve or semilunar valve, SL valve. All right. So this is going towards the lung. So that would be the pulmonary semilunar valve, and then pulmonary trunk, and then pretty much you get to the pulmonary arteries, and finally you get to the lungs. Now, pulmonary artery is exception. I will discuss this a little bit later, but those are the one of those arteries that do not carry oxygen-rich blood because they need to get oxygenated. So the lungs oxygenate the blood, you get rid of the carbon dioxide, and you inhale the oxygen. And as a result of that, oxygen goes into your lungs and it will penetrate and go from high concentration to the low, high concentration being the lung, and low concentration being the capillaries around it. So now oxygenation of the blood is occurring at this point in time. Capillaries from the lungs merge into the pulmonary vein. Again, pulmonary vein is exception. It contains oxygenated blood. Most other veins are not. Then it goes towards the left side. So you have the left atrium, passes the, again, left AV valve, uh, or also you know it as a mitral valve. This other one, the right AV valve was the, if you remember, tricuspid valves and bicuspid valves. Anyway, AV valve, and then the left ventricle, and then the ventricle contracts, passing the, again, SL valve. This is the aortic semilunar valve. And again, going back to where you start off with and such. So in a way, right side of the heart and the left side of the heart, they are a little bit different in function. The right side of the heart, as you can see, deals with a deoxygenated blood, all right? Deoxygenated blood. The left side of the heart, which is actually a little bit thicker too, because you want it, this myocardium are thicker because you want it to have more force to deliver the oxygen to all your tissues everywhere. So they require to have more force. So therefore, they are thicker. But the right side is in red color. That means dealing with oxygenated blood. There are two circuits, pulmonary circuit versus the systemic circuit. Pulmonary circuit involve the carrying the blood from the heart to the lungs and from the lungs back to the heart. And the systemic circuit involves carrying the blood from the heart to the tissues and from the tissues back to the heart. So anyways, I kind of like went over the detail of what is happening in here and the pathway and how is it organized. Next up, I would like to go over a few other characteristics about the heart. And one of those characteristics, if you look carefully under the microscope, and if you remember, you know, they were branched. The fibers on the muscles or myocardium were branched, and between them you had intercalated discs or these gap junction. They had a striation, all right? So fibers had this striation, which was again actin and myosin when they are overlapping, all right? But they also had intercalated disc, which another name for it right over here was a gap junction. We know about the gap junction. Material can go from one area to another. All right, so what material are we talking about? What substances are we talking about? We're talking about electrical impulses. When the electrical impulses are coming in from one region, it can easily go to the next region. It can easily go to the next region. So again, when you're looking at the heart contraction starts right over here on the right atrium, and then pretty soon it goes everywhere. First, the atrium it gets contracted, all right? Then the ventricle gets contracted. Either way, you'll see this interesting phenomena. If the electrical impulses or action potential starts from one area that is the right atrium, right, then it could spread easily through this gap junction because they have a space in between them, and electrical impulses are very, very fast. So what I'd like you guys to know are two kinds of cells, all right? One kind of a cell, pause the video for a second. Okay, one type of cells in the heart that are actually right over here, all right? They are known as autorhythmic cells. Autorhythmic cells, now on, we're just going to abbreviate as AR cells. All right, it's easier to refer that. All right, and then you have the myocardium, or here, or the myocardium, pretty much the cardiac muscles, right? All of these are the myocardium in here, right? These are contractile cells. For contractile cells, now on, I'm just going to use CC cells. It's easier to refer to it. So what I like to do now is kind of like giving you all a little bit of a perception of what is the sequence of excitation, or perhaps this is a conduction mechanism. Conduction of the mechanism, or how the electrical impulses and generating, and where do they go, where are they going. This can be easily shown on this slide. And here are the sequence of events that are taking place. One is the cyanoatrial node, or the pacemaker. I'll explain this. There are certain cells known as pacemaker cells or nodule cells. Different books use it differently, but they all start right over here. Where are we? We are in the right atrium. All right, which again communicate with the AV node or atrioventricular node. From there, you could track it down, the electrical conduction mechanism. That's what we're looking at. Number three, atrioventricular bundle or bundle of His. All right, so you could see the bundle of His where it's pointing at right here. All right, then there is a bundle branches. Now they kind of like divide and they go to two routes, one to the left, one to the right, kind of. All right, so that's bundle branches. It branches out, as the name of it implies. And then finally, you have the Purkinje fibers. You will see the Purkinje fibers in here, and you could see it in here, and in here, and so on. So if you notice, there is a line showing you in kind of like yellowish, and there is another line or coloring that is showing you as purple, pink. The pink color are myocardium. All of these pink color are myocardium. These are the contractile cells. All right. So because there are gap junction electrical impulses, they could go from one cell to another. In other words, they could go from the SA node to these contractile cells right here too. Right. The bottom line is first, pay attention to this one. Atrium contracts, both right atrium followed by soon after the left atrium. They contract first because they're closer to one another, right? Then what happened is the electrical impulses, they have to go pass through these Purkinje fibers in order to get to the contractile cells. So then you have the right ventricle and the left ventricles that are contracted. But you should know these five uh, sequence of excitation because it's important in our discussion. Once again, first is the autorhythmic cells, which are located on the pacemaker cells or these yellow ones or AV nodes and so on. This is a location where action potential generates. Action potential generates there, and then it will go towards the ventricles, and the ventricles contract as a result of that. All right. So now we wanted to take a look at first the process of action potential in this pacemaker first. All right. Then, which are the autorhythmic cells. And then after that, we will take a look at the contractile cells. All right. So let's go ahead and dive inside these SA nodes, or perhaps the autorhythmic cells, and see what kind of channels do they possess, and what do we need to know about that. So we are going inside of the SA node. So this is, for example, is the SA node. And again, is the CC cells, contractile cells. All right. I'm sorry, it's not autorhythmic cells, sorry. Autorhythmic cells. So during the autorhythmic cells, we have, I'm just going to draw you one. It doesn't mean that I'm going to draw everything for you. Keep in mind that many of those channels that we discussed earlier still are in place. So let's say this is one of the cells. And over here, you have the gap junction. Now, the gap junction allows the communication, and you have more than one, I'm just showing you one, with the contractile cells. So this is the CC cells, this is the AR cells. Now, Still, you have sodium potassium pump that pumps 3 sodium out and bringing 2 potassium in. I'm just showing you one. You still have those leak channels, sodium and potassium, okay? So I'm not gonna draw those, assume that they're there. But now I'm gonna show you a few things that might be slightly different. One is an unstable sodium channel. Unstable sodium channel means that this sodium gets open and closed uh, because due to the instability. Then you have a calcium channel that is voltage gated, and you have potassium that is also voltage gated. All right. So this one is for potassium. This one is for calcium. These are all voltage gated channels. So right now they're not open at the moment. And this is for the sodium unstable channel. Oh, all right. So that's the idea, kind of. Okay. Now, currently inside of the cell is about -60 now. -60 millivolts, and the permeability to potassium is very, very low. That means potassium is not getting in. It's closed, as you can see. Now there could be, this leak channels and so on. That it's very similar to what we discussed earlier. All right, but let's go ahead and take a look at, due to the unstable sodium, and we know there is sodium higher on the outside because of the sodium potassium pump. So some of the sodium start coming in. But sodium coming in is not going to drastically change the potential, resting potential yet. All right. So this, as the sodium comes in, maybe it gets to around -40 millivolts. All right. -40, -45. So it's about maybe 15, 20 millivolts. And all of a sudden, what happens? This is the threshold. As a result of that, that causes the opening of the calcium channel. In this case, we'll call this type fast calcium channel, because as the calcium channel opens, calcium that is higher outside, they start going inside. All right. So as a result of that, a lot of calcium are coming in. This now changes. -40 is going to change to, positive territory now. Let's say +5. That's a big jump right there. All right. So it's not +30. Don't memorize those things. Like I said before, each cell might be slightly different. So these are right around there, maybe +5 or so. And that's enough to open up yet another channel. And that is potassium channel. Potassium channel permeability increases. So what that means is I have to open it at this point in time. And as I open it, you can see what happens. Potassium leaves. All right. And again, we consider that as a repolarization, versus as the calcium came in, we consider that as a depolarization. So this is repolarization, and for the calcium was depolarization. So few things. Calcium was fast, voltage gated channel, right? And the calcium was the cause of the depolarization. All right. Sodium set the stage for that. All right. So again, of course, you'll have many more nerve because they're supposed to propagate. But on this one, I just showed you 3. Same thing, it starts again. So another sodium nearby, opens, and then calcium, and then potassium, and you can see how they can propagate. All right. So this depolarization a little bit is occurring because it's -70. Now you have less negative, and we said that anytime you're going towards the positive territory, it's a depolarization, but we call it a slow depolarization. A slow depolarization from here to here is called a pacemaker potential, or a slow depolarization. All right. So it's once again, number one, a slow entry of sodium. They don't just come in a lot and then causing the major depolarization. Very little bit at a time comes in. All right. So you need to picture this. They're not rushing inside anymore. Okay. They're just taking their time and they're coming in slowly. This next up, so this is unstable resting potential. It's called pacemaker potential. Slowly sodium comes in, and then that causes the calcium channel to open, the voltage gated channel, all right, and this causing the rising of the phase of action potential or depolarization. Then it's the repolarization and the potassium leaving. And there are more to it, but let's go ahead and take a look at the graphical representation of this real quick. Graphical representation of this is showing you, we started off as a resting potential -60. Because they have an unstable resting potential, a slow sodium entry comes in. This is a threshold, around 40 is your threshold, all right? So once it reaches that, it could cause the calcium channel to open, so therefore now calcium are pouring in, all right? Pretty soon, the amount of calcium in and out, again, because inside of the cell was negative, calcium is positive, is electrochemical gradient that we discussed in the action potential. Same thing holds true in here. Bottom line, you can see that they are working, and they are coming inside, and now you can see that you're going in the positive territory, +5 or so. But very soon, there is not much calcium or going in because they kind of like reach equilibrium. At this point in time, because you reach the higher threshold and the potassium channel are slowly closing, opening, it slowly opens, and again, the process of repolarization is occurring. Right? There's not really a hyperpolarization or anything like that. So as the potassium is leaving, again, same thing happens again. I mean, this is the same thing as it happened in here. A slow depolarization of pacemaker potential, and then followed by depolarization, followed by repolarization. These are all happening in the autorhythmic cells. Okay, so let's go ahead and take a look at what we discussed so far. All right, now what? Well, now you have some calcium that came in, is positive. Due to the sodium-potassium pump, there were also some potassium inside too. Not all the potassium is leaving. There are some potassium inside too. Because of the sodium entry, there is also some sodium inside of it. So inside of the cell, you have a lot of cation, potassium, sodium, calcium, they're all cation. These cations, all right, they can get pulled through the gap junction into the contractile cells. Contractile cells, remember, the cells are negatively charged. We discussed the reason why that is, all right? So because there is an attraction positive to the negative, and mainly because of the proteins that are negatively charged, all right, they're going towards the negative side, all right? Which we now going over the contractile cells very shortly. But I wanted to show you something. Going back to the electrical conduction mechanism, right? Remember this one right here. We are at the pacemaker potential right there, all right? Action potential just got generated, all right? Now what? Now we need to get this action potential in here, all right? So all of these, they're communicating with one another. We wanted to see how is it going from here to the myocardium. And through these gap junction, they can communicate with one another. And that's what we are going to take a look at next. In other words, we're going to take a look at the action potential in the contractile cells. So these are the contractile cells. Positive ions coming in. Now what? All right, that's what he's talking. Now, to make it simplify, and I need a little bit more space, as you can see. So I'm going to take this and show it to you on the next picture. So over here, you had this gap junction, and some of the positive ions, they came in towards here, right? The calcium, sodium, and all that. Now, in here is negative, about maybe negative 90 millivolts now. All right, so they're very negative and attracting the positive ions. You still have uh, the you still have the uh, similar channels. So let me go ahead and draw you the channels. Currently, these channels are all voltage gated, but they are closed. So this is for potassium. This is for calcium, voltage gated. And lastly is for sodium. Oh. Again, I'm just showing you just three, but in reality, they're propagating, right? There are more channels up ahead. You could imagine that. Again, they have the sodium potassium pump somewhere all over, actually 3 sodium out, 2 potassium in. So that contribute to being negative. There are proteins that are negatively charged as well. All right, something about the contractile cells. Again, they have this gap junction, and there are other contractile cells in the near vicinity, and so on. So it's similar. Uh, Once we understood what is happening in here, we know the same thing can happen in all other ones. And as you recall earlier, what I just told you, the atrium contract first, and then it reaches the contraction, continues with the ventricular contraction. All right, so you still have actin and myosin in here too. If you recall the myosin heads, you know, and you have the actin, for example, they attach to the actin or the thinner filaments and so on. So those are in place. You still have the sarcoplasmic reticulum that holds the calcium. This is SER or SR, sarcoplasmic reticulum, which consists of high amount of calcium in here too. All right. So you'll have all those already. Okay, you have the T-tubule. All right. So eventually the T-tubule is going to communicate with the terminus cisterna of here, and it could release the calcium. All of that you already know. And the calcium binds to troponin, move to tropomyosin. So cross-bridge cycling is occurring, and therefore you could contract. The contraction part, I do not want it to give you redundant lecture. I kind of like went over it really quickly right now, but it's pretty much similar. But what is different is these positive ions are coming in right away. They are opening up these channels. That is, the sodium channels are super sensitive. That's why we call this fast sodium voltage sensitive, fast sensitive, voltage sensitive gate. That means they're coming in really, really fast. In other words, you have a lot of sodium outside because of the sodium potassium pump and such. All right, now they're rushing in. Remember, that was not the case in the pacemaker potential, just a little bit at a time due to instability. This one, because they're voltage sensitive and the voltage is changing, right away they're opening and lots of sodium are coming inside. So that is going to make the cell depolarize very, very quickly. So that's the depolarization phase. The depolarization phase is rather quick, folks. It's really, really fast because of the fast sodium channel that are voltage gated, all right? So this is going to rapidly opens up many sodium channels. So it's going to cause the resting potential to actually become very positive. Now it's maybe about positive, let's say 30 millivolts. That's a lot. We went from negative 90 to positive 30. That's depolarization right there. So that's the first thing that is happening, depolarization. All right. Now, again, similarly, at the end of this phase, there will be a channel inactivation. Sodium channel is going to be temporarily inactivated. But this depolarization is going to open up the calcium channel. Now we call this a slow calcium channel. It's a slow, all right, a slow. I know earlier we said that the potassium was a slow, and this one is a slow as well, because it's different. That's what they call it, a slow calcium channel. Now, influx, that means there's a higher calcium outside. They're going to go in, all right? But they're not going to go rushing or anything like that. A little bit of it's going to come in, all right? And it's going to keep the cell still depolarized. Now, at a similar time, the channel of potassiums are opening and some few potassium is leaving, because remember, they are sensitive to the voltage gated channel as well, and they are also kind of like slow, so potassium is leaving. This is called a plateau phase. Plateau phase. Two things happening. Calcium is coming in, potassium is going. So kind of like resisting one another. There's not going to be a major repolarization yet. But pretty soon, what happens? The calcium channel close and become inactivated. Close and inactivate. They have those inactive gates, inactivation gates, and as a result of that, they don't continue to be open, they close. But potassium is still is open, and in fact, more potassium channels are opening, which causing more potassium to leave, which setting up a stage for number 3. So number 3 was the repolarization. So step 1 was a depolarization. Step 2, plateau phase. Step 3, the repolarization phase. As the potassium is leaving, again, the cell will get repolarized back to where it starts again, ready for another contraction. But now, think about all these positive ions that came in. Think about the sodium channel that was open and the sodium came in. Think about the calcium that came in. Think about not all the potassium is going to be leaving. So still have a lot of positive ion. These positive ion, they can go nearby and do the same thing on the nearby contractile cells. And therefore, this is going to continue. Contractile cells of one is going to continue with the next one, with the next one, with the next one. And you can see how they are spreading throughout the ventricles from the atrium, all right? So let's go ahead and take a look at the graphical representation of this. You might have to watch this video several times in order to understand this. All right, so here is the what is happening in the contractile cells. All right, and the first part is the depolarization. So remember, positive ion came in from the autorhythmic cells, and as a result of that, you could see you're going from negative 90 or so all the way to the positive maybe 30. So during process one, depolarization, fast sodium voltage gated channel are opening, sodium is rushing inside, causing the membrane potential to be positive. So you're changing from negative to positive. That was depolarization. Take a look at number two. That was the plateau phase. Yes, some calcium is coming in, some potassium is leaving, and that is causing the prolonged or duration of the uh, depolarization to be a little bit longer because they're still resisting. They're going opposite of one another. Calcium is coming in, potassium is leaving. They're kind of like checking each other's balance. But pretty soon, those calcium channels, they start getting inactivated. And as a result of that, you could see as they are getting inactivated, they are slowly not working anymore. So no more calcium is coming in. But the potassium, they do not have inactivation gate. Potassium continue to leave. And that is setting a stage for repolarization, and that is the story of the action potential in the contractile cells. What did we accomplish? Let's take a look again. What we accomplished, we started at the autorhythmic cells that are the yellow SA uh, nodes and the AV nodes and such. And then we spread them. We spread them throughout via the gap junctions or intercalated disc. They are communicating with the myocardium. Myocardium making up the mass of the atrium as well as ventricle, more of the ventricle obviously, but one by one, the electrical impulses, they can travel through them. As a result of that, you see the contraction of the atrium first, and that's very important for our discussion coming up, and then followed by the contraction of the ventricles. And that's electrical conduction system tells us the same thing. Start off at the atrium and then end up in the ventricle. Right? It makes perfect sense because that's how they are spreading. All right. Now that you learn the process of the action potential, you really need to go back and find out which channels are slow, which channels are fast, what type of the channels do you have, and what is really happening. All right. Now, as far as the uh, contraction of the muscles, you know, calcium eventually is going to go out of the SR, all right? And we discussed about the excitation contraction coupling between the calcium and the troponin. And as a result of that, cross-bridge cycle is happening, all right? But the calcium influx is also the key to, and also from the more calcium is going to be released from the SR because the calcium is already there too. Let's take a look. See, this is the contractile cells that we discussed. All right. So because the calcium, no, this is the AR cells. Where did we go? Yeah, this is the AR cells. You're right. This is the contractile cells. You were right. Okay, so calcium intake coming in This calcium can bind to troponin too, and calcium coming in from the SR. They're both important, but the amount of calcium, uh, you know, basically is the mechanism, because what you wanted to do is you wanted the action potential to reach the SR and you're releasing more calcium, and then as a result of that, you're getting more contraction. So bottom line is that the calcium availability is important mechanism for the contraction. All right. The more calcium that you have, perhaps more or a greater contraction that is. All right. So that's something that you wanted to think about as you're going through this. All right. Impulses passed from atrium to the ventricles and again went to the Purkinje fibers, and the contraction is occurring. Now, uh, these uh, electrical impulses can be calculated and can be looked at in what's known as ECG. Sometimes it's also known as an EKG. Uh, these are the events that you are responsible for to know in terms of the electrocardiography or ECG, and you need to know what are these waves for, how do you label them. Well, the first wave is called the P wave. The second wave is called the QRS wave, and the third one is the T wave. All right, so there are three waves. What we wanted to learn is take a look at this electrical activity that is recorded by the electrocardiogram, and we wanted to see what's happening. So when the heart is contracting, it's pushing the blood throughout the body. The blood consists of a lot of these ions. And if you put an electrode on the wrist or on the leg or on the chest near the heart, and you could kind of like, the machine can calculate it for you. How's your waves look like, whether it's normal or abnormal, you have to take a look at yourself. I'm sure you've seen it in a movie or a hospital where you heard a beep sound and the person was dead because you didn't see any of these waves. And that's the idea. All right. So now we wanted to find out what are these waves corresponding to. Remember, they are detecting electrical activities, all right? Electrical activities, not contraction activities. First, earlier we mentioned the electrical impulse comes in, then the effect of contraction comes in. Same thing with the SA node. Electrical impulse comes in, communicate with the contractile cells, then the contraction is occurring. So let's go ahead and take a look at the P wave. The P wave corresponds to depolarization of the SA node, all right, which is atrial depolarization, all right. Now, if you notice, take a look, this is where the depolarization is starting. This is where the depolarization is ending. Which point in time do I observe? If my eyes is at the uh, heart, and you could see it tells you the yellow is depolarization and the red is repolarization, and we can see at the SA node, we discussed this already, on the autorhythmic cells, they start generating their action potential and they are spreading. As they are spreading throughout the atrium, all right, at what point in time, notice like in this case, it's already depolarized. Complete depolarization happens in here. Where are we? We are at the end of the P, all right, passing that too, all right? But we haven't gone to the QRS yet. So this is the still end of the P, all right? Or maybe a little bit after the curve. At what point in time if I look at the with my eyes, if I look at, or I had a capability of looking at the heart, at what point in time do I see the atrium actually contract? In other words, I see that the atrium is contracting. So for example, this would be the contraction of the atrium would look like. In other words, this myocardium went over here now. Okay. If you want to take a guess, go ahead, take a look to see if you can take a guess. But it cannot be at the beginning of the P. Why not? Because electrical impulses has to reach the contractile cells first. Contractile cells, they have to communicate with other contractile cells. Because one of them contracting, you're not going to see much on the atrium contraction. So once they spread, then they should be able to see it. So the answer is probably after the beginning of the P. And the precise answer would be probably at the peak of the P. Where is the peak of the P? The peak of the P would be right here. That's the beginning of the contraction of the atrium. And then it continues all the way probably throughout here. Okay. All right, now what? Now we're going to the third phase. Third phase is ventricular depolarization. QRS corresponds to ventricular depolarization. So again, take a look. The signal or action potential are coming in from the bundle of His to the Purkinje fibers, and they are about to get spread. But at the same time, atrial repolarization is occurring. Again, you got to go back and take a look at what happens during the repolarization, potassium leaves and all that. But basically, at this point in time, you'll notice that the atrium is relaxing. All right, so if they were here contracted right here, in here, they are relaxed, going back to original way. Okay, but the relaxation has to happen after. All right, not at the beginning of the Q. At the beginning of the Q, potassium starts leaving, and then a little bit later on, you see the relaxation. But what about the depolarization? Same thing. Atrial ventricular depolarization starts, but it doesn't mean that I'm going to see the actual contraction. When I see the contraction, basically the ventricle would be here because they are coming in from here to here. All right. So when, at which point in time do you guess that you're going to see the ventricular contraction taking place? So this is QRS now. This is when the electrical impulse is coming in. At this point in time, right over here, they already completely spread, and at this point in time, they start repolarization. It starts to occur. So this, at the end of the QRS, right before I get to the T wave, I see the ventricular depolarization ending. It's already spread. So the answer, if I'm looking at the heart and I wanted to see where the actual heart is going to contract, for example, because the ventricle is going to contract soon, then it'll be right here at the peak, middle of the QRS, or at the beginning of the R, right here, or I should say at the middle of the R. Where does it end? Right here. So from here to here is actually signifies the systole. Systole when the heart contracts, right? It continues contraction all the way to the middle of the T, right? Then where is diastole when the heart is relaxing afterwards? To the next R, which you could probably P, Q, R, S. So it'll be all the way to here. So that would be diastole. This one would be systole. Systole when the heart is contracting, diastole when the heart is relaxing. But in any event, let's go to the T wave. The T wave corresponds to the ventricular repolarization. As you can see, they start in repolarizing and then again continue and completion of the repolarization phase. So that is how uh, we can kind of like take a look at corresponding waves to what do they signify. ECG is important because at times you wanted to find out if what is the heart rate, you could do the ECG. You wanted to find out the rhythm of the heart, you wanted to take a look at the ECG, and there could be a lot of abnormalities that is unfortunate because you really have to be in the lab, but anyway, we'll do the best we can. So again, it tells you what happens in each phase, atrial depolarization, ventricular depolarization, followed by ventricular repolarization. Uh, I should tell you during the ventricular depolarization, also atrial repolarization is happening. So from the beginning of the P to the next uh, Q, if you draw a line right around here where the R is, and where the P starts. This is called the PR interval. PR interval, it gives you information about how long it takes from the SA node, the information travel or action potential to go to the atrioventricular node. If there is a blockage in here, or there is a delay in here and so on, you're going to see abnormal rhythm. In other words, the contraction of the ventricle may not ever happen the same way, all right? So it gets tricky. But the x-axis, it tells you the time, all right? And if you look at x-axis, you can see the distance between the heavy line to another heavy line, all right? And this is 0.20 second, all right? So because these are equal distance, 1, 2, 3, 4, and 5 of these, then if I wanted to know how long is one of these area, it's a small area, then I have to divide 0.20 seconds divided by 5, which I will get 0.04 seconds. That's what it's telling me. So if you add 0.04 plus 0.04 plus 0.04 plus 0.04 plus 0.00, you get 0.20. All right. So if I want to know what is the PR interval, again, I could go from here to here, and I could estimate probably, around 0.20, 0.20, 22, 24 max. All right, it looks like it's half of that, so I would say the PR interval right now is 0.22 second. All right, but how do I calculate the heart rate based on the ECG? This is related to the lab. However, if I can maybe draw another ECG here. So let's say this is a P and this is the Q, this is the R. I'm trying to exactly copy the nearby, and this is the T. So you know how to label them. Then this is the P, this is the Q, this is the R, this is the S, and this is the T that we almost got cut off. But this is the beginning of the next contraction. All right, so heart has contract and relax, and then again is contracting again the P. Very soon you're going to see contraction of the atrium, all right, which is following by depolarization of the atrium, which corresponding to the P. So if I start from the P and end at the beginning of the P, all right, this from here to here, that gives me duration of 1 beat of the heart. 1 beat of the heart consists of contraction and relaxation, and that's what I observe. But if I wanted to do the heart rate, how do I calculate this to the heart rate? In other words, how long is it taking? All right. So we got to figure it out by doing a simple calculation. All right. So let me go ahead and erase this part and use this side to calculate things for you. Okay. First, I got to know 1 beat taking how long? Starting from here, all right, all the way in here. If you want to pause the video, you could. If you want to count every single one, 1, 2, 3, 4, 5, and then multiply by whatever you get by this number, you could do that too. Or you could simply go 0.20, 0.20, 0.20, 0.20, which they already did it for you. So in other words, that would be 0.80. Now, what I wanted to know, that's how long it's going to take for 1 beat. Now, if I want to know how many beats, X beats, over 1 minute, 1 minute is 60 seconds, folks. 60 seconds is 1 beat. 60 seconds is 1 minute. So if I want to know how many times my heart beats in a minute, then I have to solve for X. All right? Which I could just show it to you in another area so we can see it a little bit better, huh? 1 beat over 0.80 second equals X beats over 60 seconds is 1 minute. Now, what do I do in here? Well, you can multiply both sides by 60 seconds. 60 seconds and 60 seconds cancel. So this equation becomes 60 seconds divided by 0.80 seconds, and that gives you number of beats per minute. All right. So you could plug that in the calculator and figure it out. I'll give you a moment to see if you could do that. Okay, if you got 75 beats per minute, congratulations. This is the normal heartbeat. If you remember early on, we took the pulse and it was right around there, all right? In fact, we mentioned from 60 to 100 beats per minute is normal depending on your age and other factors, but it's normal. Now you can calculate any. So what I like to do is give you guys another problem now. All right. So what I like to do now is expand this one. It's a normal sign. Okay. Don't panic. All right. Look, this is the P, Q, R, S, and then T. This is the next P, Q, R, S, T. So it really doesn't matter which one you pick. You know, distance from here to here should be the same as here to here, or almost the same. And notice why it's normal. Look at it's nice. You can see PQRST, PQRST, PQRST. Everything is nice rhythm and so on. All right. So before we go on, what I like you guys to do is see if you can calculate these. All right. Same thing as we did before. Number one, you got to start with the beginning of the P. Well, they're not labeled, so you got to label them. Number two is, where is the beginning of the P? Well, if we go ahead and take a look, beginning of the P, I'm just showing you one of them. Right here, that should be the beginning of the P. As soon as it goes up, all right, where is the next one? Right here. So take a look. Here's the beginning of the P. It's going up. QRS, T, oh, it went up again right here, right? So what you need to calculate, you got to pay attention to these little tiny squares, because now you know the heavy lines. Look at the heavy lines, the one or the darker. From another to another is 0.20 seconds. Each of these small ones, small squares, right? Those are represented by 0.04 seconds. So start counting, all right? Where does it start? From here, okay? So this is not quite on the heavy line. It looks like it's one before that. So we can say from the heavy to heavy, that's 0.20. Add one more to it, that would be 0.24. I'm here now. Add another 0.20. That's 0.44 now. Add another 0.20. So your result in this case would be 0.84. That's one beat. All right? You got to do the same calculation. Again, if you like to, you could pause the video, see if you can figure it out. But also you need to know the PR interval. Where is the PR interval? Again, what you need to start off with is where the R starts, not the peak of the R, but where the R starts. So let me see if I can point it to you. The R starts right here. So if you want to know, you have to draw a perpendicular line. I don't know if I can see this very well, but that would be a perpendicular line maybe. All right, if you have a bigger picture, you could see it. So beginning of the P again, all the way to here. And it looks like it's about 0.20. All right, 0.20, that's what it is. That's the PR interval. All right. So that gives you the idea of how long it's taking electrical impulses to go from the SA node to the AV node. All right. So again, you could go ahead and take a look at that. Now, I don't see any ST abnormal segment either. What is the ST abnormal signal or segment? Going back over here, a lot of times people that have heart trouble, right? When they go to the treadmill and they exercise and they have all these apparatus, electrode hooked to them, to their legs, near the heart, to their thing to get the ECG. They look for this ST segment, folks. ST segment becomes like this. So if from here it went up like this, right here, then the person have heart condition, all right? Maybe clogging of the arteries, maybe you have to do more, maybe the aorta is blocked, but this showing usually when the heart is under stress, your ST segment is going to be like that. We don't see this in here, all right? It's everything normal. Now let's go ahead and take a look at some of the abnormal. I'm probably not going to ask you this, but it's nice to just see it. Look, the P wave is absent in this case, all right? So this is abnormal. This is a junctional rhythm. Look at the second degree heart block. In this case, it looks like you have more P's. You know, after the T, here's one P, here's another P, and so on. So there is not a communication between the AV, the SA and the AV. All right, so they're not conducting very well. And right over here, you can see the ventricular fibrillation. This is when the person is having a heart attack. You could see it's completely erratic and doesn't make sense and chaotic. All right, so the heart is under perhaps acute electrical shock. Uh, Nothing is making sense. Please do not think these are uh, the same as the graphical representation of the action potential that we discussed. It does not look anything like that at all. This is the graphical presentation of contractile cells of action potential, and this is the graphical representation of the uh, autorhythmic cell, AR, action potential. This has nothing to do with what we picked up in here. All right. So this is the uh, electrocardiography. All right. These are basically uh, electrical activities that can be collected by the apparatus ECG, and we can look at it and monitor the heart that way. All right. So this part you need to take a look at in detail, all right, and review it as much as possible. Now the heart sound can give us more information, and you usually hear the lub-dub sound. When you hear the heart with the stethoscope, you hear the lub-dub, lub-dub, lub-dub. So the first sound is actually telling us when the AV valves are closing. All right. This signifies the beginning of the systole. That means the heart is contracting. The second sound, the dub sound, is actually whenever the SL valves are closing. So this is telling us at the beginning of the ventricular diastole. All right. So once again, as the valves are open and closed, when they're closed, you hear the sound on your stethoscope. If you put it on the heart, you will be able to hear that. Now, because you're not going to be able to do it if you haven't done it before, you could probably search that up in YouTube and put heart sounds, and there's lots and lots of uh, sound along of how you can listen to it and so on can be revealed. But you place the stethoscope in a different area that is closer to the valves. These are the four valves. As you can see, the AV valves uh, and the SL valves. So in order to, if you go to the physician, notice like, he has the stethoscopes in his ears and he's putting it in a different area of the heart. Again, he wanted to put it closer to all the valves. It's a good idea to kind of like do this so you could listen to these valves. All right. When these valves are defective and they don't work properly, then you might be able to hear a hissing sound, which is also known as heart murmur. All right. Now, the valve's job is to prevent backflow. So when the blood is passing through it, it doesn't backflow. Similarly, you could think of it as the valve of your tire of your car. When you put in the air inside of the tire, the air is not coming out because that valve is only one way. You can only put air in inside of it. It's not coming out. Air is not coming out because the valve is working properly. What if your valve was defective on your tire? Then you will hear the hissing sounds. The air is coming out and is leaking through the valve. We're not talking about when you have flat tire. We're talking about valve is defective, where you put the air in it. Same thing in here. When you have defective valve, now, the process of sending the blood towards the right places and so on, that everything is going to get messed up now. Oxygenation of the blood and how they work and everything. So for that, we need to listen to the heart sound and get information about these sounds. So the aortic valve, seminal aortic valve, and pulmonary aortic valve, these are this one. This is the pulmonary seminal valve. This is aortic seminal valve. All right, again, we call it like a SL valve. All right, so you have to place the stethoscope in the second intercostal between the ribs, all right? And again, left and the right sternal margin. Sternum was the flat bone right in the middle of the chest. You put it on the right, you put it on the left. Second intercostal. How do you know where that is? Well, you could count the ribs. So while you are listening, you could actually touch on your, you know, anterior portion of your chest from the top, all right, and go down, you feel the ribs, all right, and you could count on them. You will count number one, number two, number three, and so on. So between two and three is the second intercostals. That's where you put them, and then you'll be able to listen to them. You've seen doctors carrying the stethoscopes on their neck, or the nurses even. Mitral valve and tricuspid valve, these are the AV valve. AV valve, AV valve. So you got to go a little bit lower. You got to go to the fifth intercostal space, right? And again, you could just listen to it, and hopefully you don't hear any hissing sound, background noises. You could just hear the lub dub sound. It's also a good idea to listen to the rhythm of it, all right? When you're playing a piano, it has certain rhythm to it, and it comes one after the other. Same thing with the heartbeat. For example, lub dub, lub dub, lub dub. You know, first lub dub and the second lub dub depends how long it's going to take. Depends, right? But the second lub dub to the third lub dub, it should be the same amount of time as the first lub dub to the second lub dub. Here's what it will occur if you have abnormal heart sound, which again is abnormal rhythm sometimes, or lead to that. Lub dub, lub dub, lub dub, lub, lub dub, lub dub, lub dub, lub dub, lub. So you could see that in between there are, what is that telling you? The heart is contracting so fast, and then it's slow, and then it's slow, and then contracting so fast again. It shouldn't be like that, right? Something is wrong, all right? We're not going to go and talk about all the diagnosis and what it can happen, but that's the idea. All right, so that was pretty much the first part in terms of the action potential, the heart sound, and the ECG. Now we're going to shift to the second part. To make it easier to post it and would take less time to download, I would like to finish up at this point and put on the second part for you at the later time. I hope you learned something and you find the lecture useful. I will put the second part as soon as I'm